Silence for 2 seconds. Hemorrhagic complications represent a principal cause of morbidity and indeed mortality in both perioperative and critical care medicine. V-elastic hemostatic assays, VHAs, are a genuine paradigm shift in how we monitor coagulation. They provide a real-time global assessment of hemostasis, and this facilitates a crucial transition away from empirical transfusion protocols towards precise, goal-directed resuscitation.
The structure of this presentation is as follows. We will first establish the rationale for VHAs over conventional testing before examining the core biophysical principles. From there, a systematic interpretation algorithm will be detailed, then applied to common resuscitation scenarios. We will define the associated goal-directed pharmacology and conclude with crucial pre-analytical considerations.
The fundamental distinction between conventional coagulation testing and viscoelastic hemostasis provides the entire rationale for the paradigm shift in our approach to coagulation monitoring.
Conventional coagulation tests, your standard PT and APTT, are profoundly limited. Because they are performed on platelet-poor plasma, they can only assess isolated enzymatic steps. They fail entirely to capture the crucial cellular interplay that defines whole blood coagulation. This limitation is not merely academic. It leads directly to the use of blunt instruments, empirical, protocol-driven massive transfusion protocols, which often result in both wasteful and potentially harmful component therapy.
In contrast, VHAs enable precise, goal-directed therapy. The evidence base here is robust. Multiple randomized controlled trials demonstrate that VHA-guided algorithms reduce overall blood product usage by 20 to 40%. This reduction corresponds to decreased allogeneic exposure and significant cost savings. And, quite critically, it is achieved without compromising patient outcomes. Understanding the waveform anatomy and its underlying biophysics is key to seeing how these systems transduce mechanical clot properties into clinically actionable data. Both TEG and ROTM operate on an identical biophysical principle. They detect the mechanical coupling that occurs between a cup and an immersed pin as a whole blood clot forms. The mechanical distinction is straightforward. In TEG, the cup oscillates. In ROTM, the pin oscillates. The clinical relevance of this seemingly minor distinction, however, lies in the transduction method. ROTM's optical detection system confers superior stability against external vibration, a non-trivial consideration in a busy operating theater, or, for that matter, during patient transport. Each geometric segment of the VHA waveform maps directly onto a distinct physiological phase of coagulation. The initial flat line, the R time or clotting time, reflects factor-dependent enzymatic activation and thrombin generation. The divergence of the trace, described by the K time, clot formation time, and the alpha angle, represents the amplification phase, which is driven by fibrin cross-linking kinetics. The widest point, the maximum amplitude or maximum clot firmness, reflects the propagation phase and the ultimate structural strength of the clot. Finally, the tapering of the trace, quantified as LY30 or ml, indicates plasmin-mediated clot breakdown, fibrinolysis. Systematic VHA interpretation requires two things: fluency in the language of viscoelasticity and adherence to a rigorous diagnostic algorithm. TEG and ROTM employ different nomenclature for what are, in fact, physiologically identical parameters. So TEG's R time is ROTM CT. K time corresponds to CFT. Maximum amplitude, or MA, is the same as maximum clot firmness, MCF, and LY30 equates to maximum lysis, or ML. Now, a critical point for trainees: although they are physiologically equivalent, the reference ranges and the numerical values are entirely device-specific. They must never be used interchangeably. This is a common and dangerous source of clinical error. For safe and effective clinical application, a systematic, repeatable framework is absolutely essential. Step 1. Assess initiation via the R time or CT. Step 2. Assess the specific fibrinogen contribution using the FIB-TM-MCF. Step 3. Calculate the platelet contribution by looking at the EXTM fibrin-TM gap. Step 4. Assess for fibrinolysis via LY30 or ml. And the final crucial step: administer targeted treatment and then repeat the assay to assess the patient's physiological response. The application of this diagnostic algorithm is best understood through VHA-guided resuscitation in specific clinical scenarios. Specific pathologies produce highly characteristic waveforms that you must learn to recognize instantly. A prolonged R or CT points to delayed clot initiation. Think coagulation factor deficiency or the presence of an inhibitor like heparin.
A low Fib10 MCF specifically isolates a deficiency in fibrinogen, which is the structural backbone of the clot. A low X10 MCF, but in the context of a normal Fib10, points directly to either platelet dysfunction or thrombocytopenia. The fibrin backbone is intact, but overall clot strength is poor. A rapidly narrowing trace, a high LY30 or ML, is the classic signature of hyperfibrinolysis, pathological premature clot breakdown. And finally, a flat line or a thin, spindle-shaped trace indicates the profound consumptive coagulopathy of DIC.
Our first case, a polytrauma patient presenting with hemorrhagic shock and a high suspicion of trauma-induced coagulopathy, or TIC. The trauma algorithm provides clear guidance for specific interventions. In this case, the initial ROTEM demonstrates an X10 ml greater than 15%, which confirms pathological hyperfibrinolysis. The immediate intervention, therefore, is 1 gram of intravenous tranexamic acid. The evidence from the CRASH-2 trial is absolutely unequivocal. To achieve a mortality benefit, TXA must be administered within 3 hours of injury. I must stress that if hyperfibrinolysis is clinically suspected, treatment should not be delayed while awaiting the FIA result. The algorithm would subsequently guide the replacement of factors, fibrinogen, or platelets based on the CAT, FIBTM, and XTEM results respectively.
Case number 2. A cardiac surgery patient who develops coagulopathic bleeding immediately following separation from cardiopulmonary bypass.
Here, the VHA trace reveals a significantly prolonged INTEM CT, well over 240 seconds. However, the paired heptime assay, which you'll recall contains heparinase, shows a completely normalized CT. This differential between the two assays is diagnostic. It confirms residual heparin effect as the sole etiology of the bleeding. The correct therapeutic action, therefore, is the administration of additional protamine, which should be carefully titrated to the subsequent VHA response.
Our third scenario, a patient with a significant traumatic brain injury who is on clopidogrel and now requires emergent neurosurgical intervention.
The VHA confirms platelet dysfunction as the primary deficit. We see a low EXTM MCF in the presence of a normal 5TM MCF. In the context of neurosurgery, it must be understood that even a minor degree of intracranial bleeding can have catastrophic neurological consequences. Therefore, restoring robust clot strength is not merely important, it is absolutely paramount. While a standard VHA identifies the platelet deficit, more specialized assays like TEG platelet mapping can pinpoint the specific pathway inhibition, in this case ADP. The definitive intervention here is the transfusion of 1 adult therapeutic dose of platelets. This is required to overcome the pharmacological inhibition and deliver functional platelets to the site of intracranial injury.
The diagnostic data derived from the VHA should directly inform our goal-directed pharmacology, enabling precise dosing of specific hemostatic agents.
Each intervention is triggered by a specific VHA parameter, and for residents, understanding the physiological rationale is essential. A FibTim MCF below 9 millimeters signifies a structurally inadequate fibrin backbone. The logical treatment is to provide that substrate with fibrinogen concentrate or cryoprecipitate, aiming for a target MCF of at least 12 millimeters. A prolonged R-time or CT indicates a deficiency in enzymatic factors, which is treated with FFP or prothrombin complex concentrate. A low XTM-MCF after fibrinogen deficiency has been excluded points to a platelet deficit requiring platelet transfusion with a simple target of normalizing the MA or MCF. A thorough understanding of pre-analytical variables and special considerations is essential. This is critical for ensuring the accuracy of your results and for recognizing the inherent limitations of the technology itself. VHAs can reveal the characteristic footprint of specific anticoagulants. Unfractionated heparin, for instance, prolongs the INTM-CT, a prolongation which is corrected by heparinase in the heptime assay. Warfarin, by affecting the extrinsic pathway, will prolong both the XTEM and INTM-CT. However, you must be aware of a major clinical blind spot. Standard VHA assays are notoriously insensitive to direct oral anticoagulants. A normal VHA trace must not be used to rule out a clinically significant anticoagulant effect from a DOAC. That is a critical patient safety point.
Accurate VHA results are critically dependent upon a meticulous pre-analytical technique. The sample must be analyzed at precisely 37 degrees Celsius, it must be analyzed within 4 minutes of collection, and it must be collected in a 3.2% citrate tube. Any deviation from this protocol renders the results clinically uninterpretable. And I will leave you with the ultimate clinical pitfall, the patient who is actively bleeding despite a completely normal VHA. This finding does not refute the presence of hemorrhage. On the contrary, it should immediately redirect your diagnostic focus towards two possibilities. First, an unaddressed surgical source that requires